in 5, 4, 3, 2, 1. We are now live.
Hi, good evening. This is Dr. Jayanth Sampath from Bangalore. Welcome to this case discussion session on movement analysis. This is an initial effort which is being made by a bunch of professionals, Dr. Taral Nagda, myself, Dr. Chasanal, Dr. Dhiren Ganjwala, and others to try and spread the message and knowledge about 3D gait analysis in India. At the moment, it's a nascent field, and we feel that having interested professionals talking, interacting about cases, and sharing knowledge will go a long way in trying to promote understanding and use of 3D gait analysis. The numbers of 3D gait labs in India are increasing quite rapidly, and I think in sync with the numbers of gait labs, I think we also need to improve the academic efforts and the teaching efforts so that enough numbers of professionals across the board, orthopedic surgeons, therapists, rehabilitation professionals, and engineers are all brought together on a single forum. And hopefully this case discussion session and a WhatsApp group that is associated with this particular group, we will eventually move on to forming a movement analysis Society of India. So that is the eventual aim, and to continue promoting and spreading the knowledge. So I invite Dr. Taral Nagda, who himself has a gait lab in Mumbai, Jupiter Gait Lab, and he's a good friend and a sound mind in terms of movement analysis. So over to you, Taral. Taral will be moderating the session for today.
Absolutely. Jayanth, thanks for allowing to moderate the first session of this society, whom we've named as MASI. And MASI is Movement Analysis Society of India. This is the first time we are all meeting together. Gait is also about temporospatial parameters. So we've started on time, which is the temporal definition, and spatial because people have joined from all over India, and people also are watching this on OrthoTV and will continue to watch this program. People from India and all over the world. So that's the special part of this program. We have two sort of players in this double wicket tournament, Dr. Jayanth Sampath and Dr. Chasanal Rathod, who are going to sort of do the batting for next hour or so. And we have 4 overs here. We have 2 talks, one each by Chasanal and Jayanth. And then this is followed by a case discussion, a focus case discussion, again by Chasanal and Dr. Jayanth Sampath. To introduce today's speakers, Jayanth I would call as Bhishma Pitama of movement analysis in India. He's inspired a lot of people. I'm sure nobody has expired because of that, but inspiration is definitely that. He has his own lab called Bimra in Bangalore. He was trained in UK in fields of pediatric orthopedics, cerebral palsy, and gait analysis. And he brought his wisdom back to India. So that's Jayanth for you. Chasanal Rathod was trained in India, was trained at Wadia, and then she went to South Korea for further interest, where she trained with Professor Kim for cerebral palsy and gait analysis, and has many awards to her credit. She's been also has presented and researched extensively on gait in cerebral palsy. So we have the two sort of specialist speaker here who are part of the MASI family. And for the first talk, I'm going to invite Dr. Chasanal Rathod. Chasanal, please share your screen. And I want to say that we have 2 parts of gait analysis, kinematics and kinetics. Kinematics is like geometry of gait analysis, and kinetics is like physics of gait analysis. So Chasanal will take you first through the angles, and then Jayanth will take you through the forces in 2 subsequent talks. People who are on the Zoom platforms, If you want to ask question, type in the chat box or unmute and ask a question. People who are watching this on OrthoTV, you can sort of type in the question box, or you can WhatsApp to me your questions on 98203298888. I'm going to repeat my number, 98203298888. So Chasanal, please start the game. Thank you.
Yes. Thank you so much, Taral sir, for that humble introduction, sir. And it's a real privilege to be part of this group and have worked with you and inspired by the Jayanth sir, Dhiren sir. And thank you so much, sir, for this intro as well. So like sir mentioned, that the gait analysis has two parts. That is the kinematics and the kinetics. And I'll be talking about the kinematic part today. So basically, gait analysis is a systematic measurement, a description and assessment of the quantities of human locomotion. So basically, it calculates and kind of describes the joint movements, the forces, and during the walk process. Okay. So the kinematics basically includes the joint angular displacements and the movement and the dynamic alignment. The kinetics include the power, force, and the joint moments created. So how does this help? So if by doing a gait analysis or studying the locomotion pattern, normal pattern, or maybe even in a pathological condition, or in a sports person for better performance, it helps to pick up any deviation from the normal pattern. It helps us in decision making in terms of therapy, in terms of change of any particular shoe orthosis, or for surgical planning as well. And most important, it helps us to quantify the results of our intervention, whatever it may be. So basically, like I said, so when a person is moving from one point to other, the coordinated movements of the upper limb and lower limb are kind of studied, and that is the study of motion. And we study this in terms of three parameters, that is the distance, time, and speed. And that's how we describe the motion. And various body segments and joint create different motions. So if suppose it's an asymmetric involvement, there might be different motions, and hence this kinematics helps us to understand all of this, and it basically records the gait pattern and helps us to see or go back and review and give more time, which would not otherwise be possible in a busy clinic. So that's how the kinematics helps us. So kinetics, which Dr. Jayanth sir will be talking, is basically the study of forces during this particular motion. And so how does the kinematic or the temporal parameter actually look like? So basically, if we see the kinematic part, so it provides us like a special information of the linear as well as any angular displacement and what is happening at the level of pelvis. So if you see the top line, it is the pelvis, and what is happening to the hip, the knee level, and the ankle level. And these segments are studied in three planes. So three planes are, if I look at it in vertical fashion, this is the sagittal plane, this is the coronal plane, and this is the transverse plane. Now, each lab or the system of motion analysis could vary or could change the way the reports are obtained. But since today we are going to be doing the case discussion, I prefer to explain it in this pattern so we can follow the case discussion same with this pattern of report. So apart from this, the gait kinematics also helps us to understand. So apart from this, the gait kinematics also helps us to understand if there is, what are the timings of the gait cycle here. So what you see, these lines dividing, the line below this side is the stance phase and the line this side is the swing phase. Now, because this child is a hemi or an asymmetric type, we see the divisions are at two different points. If it was a diplegic child, the lines would be together. Also, along with this, it helps us to get the shape and the magnitude of the graphs. So we get to know what the shape of the graph is. Is it a linear thing? What kind of bumps are there? Are the bumps or the peaks reduced? And what are the magnitudes? Are they at the level of the peak or are they decreased? And also it helps us to understand the range of motion, which is already plotted on this graph. And it helps us to know the specific events at which this particular movements are happening. So like if we know the phases or the events of the gait cycle, the initial contact, the loading response, and so on. So that helps us to correlate these particular changes with those events. So that's how the kinematic is depicted in this slide and the image. Okay. So that was it. And like I said, the event. So initially, if we go back, we used to have different terminology. And that terminology was heel strike, loading response, which has now changed to initial contact, loading response, and different type of terminology. So we'll be going through the normal gait cycle and phases of gait cycle in the next session. Today, we'll focus just on what is happening with the kinematic and how things are happening with each segment and how they're working. So before I move to each of the graph pattern, we need to understand one thing very easily. And the therapists are very much more better in understanding these terminologies as compared to an orthopedic surgeon, because they study each and everything in terms of the concentric and eccentric action or the isometric action. Even their exercises are named by such words, which initially I used to never understand until I started learning the biomechanics. So concentric, if you look at this is the stance phase and the below is the swing phase. And the concentric word means there is shortening of that particular muscle, and that helps in generating power or helps in accelerating of that particular movement. Eccentric is lengthening under tension, and they are basically decelerator. That is, they reduce the speed or the action. They work as shock absorber in that particular mode when at that point the muscle is working. And isometric are the ones who neither lengthen nor contract. They remain in a tension without any change in the length, and they work as stabilizers. So hereafter, I'll be just using the three of these terminologies and not talking about what it is actually doing. So coming to the kinematics, we'll start from distal to proximal. I'll start with the foot and ankle graphs. So this is how in the graph, so this is a gait analysis of a normal patient. So this is an adult, I think a young adolescent with the normal gait graphs. And if you see, the gray part is what is the normal, the red is, and I'll explain you these things. So, okay, so let's start with the ankle and foot graph. So we come here. So if we look at the stance phase for the ankle and foot graph, the stance phase is the ankle rockers, what we know as. And if you look at this, these rockers are 1, 2, and 3. And what the graph depicts here is 1. Here there is 2 in the mid stance and 3 just before the pre-swing, before the heel off. Okay. So these are the 3 ankle rockers. And how do they work? So the first ankle rocker, that is the initial contact, which we label as, is mainly it comprises mainly because of the initial contact is to initiate the first contact of the foot, that is 1. And the first rocker is what actually depicts with the initial contact. And it happens because there is an eccentric contraction of the tibialis anterior muscle here. So there's an eccentric contraction causing this particular movement. And when we look at this can be like at least a 5 to 10 degrees of 3 to 5 degrees of dorsiflexion, or it might change or vary from individual to individual. And from here, it causes slight lowering of the foot till we get the flat feet in the next phase, that is the loading response. And then in the loading response, if you have a look, the next part here or the one here. So from the anterior, now the eccentric contraction has gone posteriorly in the gastrosoleus. And this is basically to absorb the forces here. So the plantar flexion the plantar flexor lengthens. It absorbs the force so that the foot can land without any sudden jerk or a slap. So in case there is a foot drop, then we see that this movement might not work here particularly. And in this case, the feet might just slap or have a circumduction for clearance. So since this is normal, it's very easy to understand that because this is having a eccentric contraction, we are able to get this particular initial contact very well here. So coming to the next part, that is the loading response, which kind of coincide with the second rocker here. And if you look at this part, so from here to here, it's the second rocker, which is a continuation of loading response and further continued towards the mid stance. So what happens in this particular two phases? So here, as the feet lowers, the body tries to advance forward. So the body vector advances. And if you see here, basically, like I mentioned, the muscles here are in eccentric contraction. The hams and the gastroc, they remain without any particular tension there. And what we look at further, the third rocker or the terminal stance, which is happening. So the mid stance and these are, they continue in that particular phase as the body advances forward. And the next part is the terminal stance, where we see now there is a slight plantar flexion, which happened after the lowering, and then there was a flat feet. And at this particular point, now we need to prepare for the push off or advancement, or the point where the heel will be pulled off before the pre-swing. So this is here where the first time the power is generated because of the concentric contraction or shortening of the gastrosoleus. And here this power generation causes us to give this forward movement as well as do the heel off and move forward during this particular phase. Okay. So what happens in the swing phase further? That there is, if we look at this, then the swing phase is the second arch where the plantar flexion has come. First was here, and then the plantar flexion is again here. So if you look at these, this is the plantar flexion and dorsiflexion. So this is the second time where the plantar flexion has happened. And then this also initiates the knee flexion. So there will be an initiate, which causes the knee flexion to initiate. So with the heel off, the knee suddenly flexes forward. And if you look at this, then there is the mid or the initial swing, which is again now it is moving towards dorsiflexion. So the initial from pre-swing, we are going to the mid swing or the initial swing, and then the mid and terminal swing part. And these are the second phase where the dorsiflexion is going to happen. And here we are going to have a foot clearance and further limb advancement.
I got the mic.
Can we have mute for everyone else? Yeah. So now this was how it looks in the sagittal pattern. And if we look at the coronal pattern or the foot progression, that is the transverse plane, the rotation pattern. So in the coronal plane, we see two activities, that is the inversion, eversion. And again, different labs will have different terminologies like adduction, abduction, based on how the report system is. How it actually works, it's a small range of movement. So it's a range of movement from 0 to 10 degrees in each of the plane. And what actually causes about these inversion, eversion is the subtalar joint movement. And these movements, if you see, they occur both in the stance and the swing phase. So the eversion here, if you look at this point here, which is the explanatory thing. So the eversion, and so from initial contact till the loading response here, there is a peak again at mid stance, followed by just pre-swing, it again goes back into eversion. So this particular point, so when there is a heel off here, it kind of causes the feet, there is a heel off and the foot is in a drop position in order to clear and move forward. Here at this particular point, apart from the subtalar joint, the metatarsals and the metatarsophalangeal joint and the toes, they come into action and they prevent the foot kind of slapping or dragging and help in clearance and prepare the feet again for an initial contact back. So apart from subtalar joint, the other joints involved, they work in the pre and swing phase here. So if we look at the rotational plane, So at the ankle level, again, very little movements are happening, and they are again secondary to what is happening at the subtalar joint level. So whenever the ankle is, so this is at initial contact and this is at loading response and further, if you see, a very small movement happens at the ankle level in this plane, and major movement happens in the sagittal plane. So that is a much more important graph, but it is important to understand here that during the dorsiflexion or progression of the leg, the subtalar joint goes into little rotatory strain, and the entire function of the subtalar joint here is to decrease whatever rotatory strain is happening. And in that process, the mid-tarsal joint, in order to prevent a shock absorption, or they start working in the terminal swing. But when we see here, when the subtalar joint goes into eversion, apart from the toes, the tibia also, or the calcaneus and the tibia start rotating. So the calcaneus tends to rotate laterally, and the long in action with the long axis of the tibia, and the tibia will tend to rotate internally. So as from the initial contact, we move ahead towards loading response here. So we see that the calcaneum tends to rotate outward and the tibia goes more of into internal. And then we see this particular thing which is going into abduction here or eversion. And that's how we have a foot progression angle which goes externally and tends to remain external throughout, with slight changes again at pre-swing to prepare for the initial contact, which are again being worked by the metatarsophalangeal joints as well. So from the ankle joint, the next part will be the knee joint graph. So again, in the knee joint graph, unlike the ankle where there were different movements and more movements in the sagittal plane, same with the knee here, there is a larger range of movement in the sagittal plane, that is between around -5 or -15 to 70 or 60 degrees. What they say is 60, but the graphs are plotted between -15 to 60 again, based on 70 based on the individuals. And in the transverse plane and coronal plane, very fine rotatory or adduction abduction movements happen. And many a time this graph, the knee adduction graph, is considered as the representative graph to understand if our markers are rightly placed or not, and if the gait cycle is a representative cycle or not. So if this graph is not right, then the gait cycle or the gait trials have to be repeated in order to do the entire analysis again. Okay, so let's look at the stance phase quickly. So if we see that the knee graph is quite easy graph and very, easier for us to understand as well as compared to the ankle, where there were plantar flexors as well as the dorsiflexors working at different level and the ankle rockers making things little difficult. So here the knee flexion usually starts at around 5 degrees, and there are studies which say that it can be into slight patients can have, or normal individuals can also have hyperextension or up to 5 degree flexion. So they begin with either hyperextension, 0 flexion, or 5 degree flexion. And then from an initial contact at this particular point, it goes, and in the loading response, there is rapid flexion of the knee. So this is when at this particular point, you see that the quadriceps is not the one which is causing this. And the quadriceps remains totally neutral throughout the phase. Although the quadriceps is the major muscle acting at the knee level in terms of causing knee extension, but it doesn't work at all entire during this particular movement, and it remains in an isometric state. So at that particular point, from here to the mid stance, it goes into slight extension again, and then it is preparing for the pre-swing. So this is the point where there is sudden second wave of flexion at the terminal swing, because now it is going to flex much more higher in order to clear from the ground and move ahead. And also because now this point is where the double support is happening and the other foot has come in contact. So the moment the other foot touches, this foot gets a chance to clear and suddenly goes in flexion, rapid flexion, so that it can advance and move ahead. Okay, so now coming to the mid stance and the terminal stance part of the knee. So these are just completion of the earlier phase from clearance. And they basically stabilize the weight when shifting from one leg to the other and preparing for the pre-swing phase again. And at the end of the terminal stance here, the knee flexion suddenly started flexing. You look here, and so now at this particular point, we go to the swing phase. Yeah, so these are the swing. This was the stance muscle action, and we go to the swing one. So here in the swing part, there is, as I said, that because there is sudden flexion here, and it leads to around 40 degrees of flexion. So if you see from here, it goes around to 40 to 60 degrees of flexion, and it kind of unloads. So even at this particular point, so here again, the rectus doesn't work. What works is basically the just some part of vasti they work. It's not the entire rectus femoris which is working. But what is important here is the psoas, which goes into a concentric contraction. So the hip flexion here is more important, and it goes into the hip flexors go into a concentric contraction and thereby moving ahead. So at the initial swing, the mid swing, and then the terminal swing, here we are just preparing for the swing phase. Here we are preparing for the advancement, and it is still advancing, and then it is preparing for the stance as we go ahead. So that is what are the events happening here particularly. And like I mentioned, so the quadriceps was always kind of working as a stabilizer. And what helps us to move ahead was in the loading response, what we saw before is the tibia, which advances over the ankle. So that is the thing which causes the leg to advance ahead. Okay. And at some point of time here, there is the short head of the biceps femoris, which also causes slight knee flexion. So although it's not visible here, but that is at one point of time, it works along with the hip flexors. And in the terminal swing, again, there is full knee extension, which we see here. So the knee is in full extension. And in order, we had seen how the foot is, in order to remain up and not go into sudden slapping or down, how the metatarsal joints and other things have worked during the swing phase in the foot what we discussed before. Okay. So coming next to the hip joint graphs, and yeah, so these joints, how I mentioned is we had very small little movements, and the major movements are happening here. And because the joint is very much stabilized by the quadriceps and the hams, very fine movements happen, and we don't discuss either of this unless there's a major malalignment in terms of femur and tibia. Then yes, we need to know the knee rotation before having any sort of intervention done. So now the last two graphs are the hip joint and the pelvis. So if we look at the hip graphs in the sagittal plane, we see that there is, so in the hip joints, we see that initially it starts with a flexion, which is around 30 degrees of at the initial contact. The hip is at around 30 degrees of flexion, which is the functional position at the initial contact. So we don't walk with more flexion or less flexion, but it just goes up to 30 degrees of function. And in the loading response, again, the sagittal and the coronal plane movements happen. And only when the other limb has kind of pushed off, then all three plane movements happen when we look at the hip joint here particularly. So, yeah, sorry. So again, the hip muscles, they have particularly two functions. One is to decelerate the activities, and second is to restrain much of forward movement of the body during this entire gait cycle here. And what is working constantly is the gluteus works here in terms of the contraction and helps us to prevent further much more forward movement. Like I said, it will restrain the forward movement and keep. Here the hip extensors are very important, and they try to control and help with the movements here. And we see it goes back into around same degree of 30 to 40 degrees of flexion, thus preparing again for the initial contact with the same amount of flexion. And lastly, the pelvic joint graph. So if we look at each of these, so this is in sagittal plane, and this is the coronal, and this is the rotation. While these don't match with it, these are matching the rotation, and this is the sagittal, and this is the oblique one. So in the sagittal plane, again, there's a fine movement possible of around 4 degrees, and it is basically controlled by the hams and the hams and the rectus muscle when it comes to what kind of tilt it is. And particularly in the pre-swing phase, if the rectus is into contraction, or if the hamstring has a large, a large knee FFD, then there are chances that we might have some abnormal bumps in this particular graph. And if the hamstrings are very much contracted, then these are posterior tilts. And this works basically because the pelvis doesn't move as such. The role of the pelvis here is to just keep the trunk stable. So it is just trying to keep the trunk stable, and whichever muscles are acting in whichever pattern, or they are contracted or weak in that particular area, it will show a tilt. For the pelvic obliquity, again, it might change if there is a limb-length discrepancy or if there are adductor weakness. So basically, it's more of hip extensors and the abductors which control the pelvis, and they kind of stabilize and balance. So these two movements happen, and in case of there's a limb-length discrepancy, there could be an obliquity. And pelvic rotation occurs in correlation with the hip or in correlation with the knee. In order to maintain a normal foot progression angle, the pelvis could either retract or protract. And normally it's just 10 degrees, but further in the case, we'll see that in hemiplegics or asymmetric die, how this retraction or protraction is much more as compared to this small little movement which is possible. Yeah, so apart from this, we need to understand that there has to be stability of the foot in stance. There has to be a very good foot clearance, what we learned before from the graphs. And there has to be appropriate swing phase pre-positioning of the foot. Just like we mentioned, how every time after the swing, there is a pre-positioning for the stance, as well as same for the swing as well. There has to be good temporospatial parameters, and particularly step length is important, and the gait has to be an energy conserving gait. So with these graphs, we always try to explain the parameters in this context, if the gait is normal or is it not normal. So that's it. Thank you so much.
Chasanal, thanks. That was really clear, lucid, and extensive. And she covered not just the changes in ankle, knee, hip, and pelvis, the angles during the gait cycle in all the three planes. She also told us about what muscles work. And I'm sure this is the basics, absolute basics of learning the gait. And what my suggestion is to the delegates who are watching this is you have to draw your own graphs, memorize it, because only when you know what are normal graphs, you will know what is abnormal. Though when we see a gait analysis report, the reference graphs are always there, but it's important to go through each phase. And even if someone wakes you up at night, 2 a.m. and asks you what happens to the ankle in the early swing, pre-swing phase, you should be able to answer that. Chasa, I'm going to ask you a question, is that when we see the graphs for right and left side, they come on the same timeline. Although we know that the initial contact on the right and initial contact on the left does not come at the same time. So, in terms of the angles, would you prefer both the phases being superimposed in a way they actually show the timeline of gait study, or you prefer them coming one onto other? So I'm going to ask you, and then I would also request comments from Jayanth on that. And if anyone wants to comment, they can answer.
So, so like Sir mentioned, and I said that looking at the knee adduction graph, we need to do multiple trials. So every child undergoes 10 trials, and they are kind of graphed as right side one graph and left side one, and later they are superimposed. So for an ease to understand and see, yes, the superimposed graphs are good, like a quick look. But in case there is asymmetric child or hemi, it would always be good to turn another page and go through the right side first and the left side again. So, and the reports always give us 3 pages. So I think we have data and it can be used the way we want, so based depending on the child again.
So,
Jayanth,
the question that Taral asked is, is it more helpful to know in real time how the two legs are moving or artificially? Because the way the two initial contacts of the two lower limbs are superimposed on the graphs, it almost looks like the patient is hopping, but that's not the way. We have a reciprocal gait. But the two lower limbs, the left and right lower limbs, move independently of one another, except at the pelvis. So at the pelvis, both the right and left limbs interact with one another because it's a single segment. So you will have what happens on the right side will show on the left side, and what happens on the left will show on the right. But otherwise, the two limbs move pretty independent of one another. So it's just a gait analysis convention that we have the two initial contacts superimposed. Otherwise, it will be really confusing for us to actually understand how the two legs are moving. If they are sort of not only the two are, if they are exactly separated temporally by the normal, whatever is the separation of the two initial contacts, then it has to look really messy. And I do that. There are programs, software programs by which you can separate the two initial contacts and look at them in real time. But it becomes very, very confusing. So I think the current convention is a compromise, but sometimes you have to, it'll make you think. And as we go into more advanced gait analysis, I will show some examples of how the right leg is influencing the left hemipelvis and the left leg is influencing the right hemipelvis. So once you start to understand these complex interactions, then real understanding of human gait comes from that. So I think that's a very relevant point that Taral has made.
So Chasanal, thanks for the wonderful talk. There are no other questions at present. Now, I'm sure people will have more and more questions as we go along. But with this, I want to keep it engaged and want to request Jayanth to teach us a very complex topic. So it's easy to understand kinematics. Equally difficult it is to understand the kinetics. And Jayanth makes it really simple. So over to you, Jayanth, for this.
So thank you, Taral. So first of all, I'd like to thank Dr. Dheeraj Ganjwala. I have, with his permission, taken some of his stick graphs, which are really useful for understanding gait. And I'm very happy that Dr. Dheeraj is part of this talk with us. So kinematics that Chasanal talked about is about how things move. Kinetics is about how things work. And we use something called inverse dynamics and the Newton-Euler equations. And dynamics is basically the physics of if I apply a 1 Newton force to an object, how far will that object move? So that is dynamics. So inverse dynamics is if a 1 kilogram object moved by 1 meter, which is what we see on the kinematics, is we actually see the movement of that object. Then we can also work out by inversing the equation how much force should have acted on that body. So that is the way we actually look at or calculate forces in a gait lab. So we are seeing the body moving, we know the weight of that body, and we know the direction of movement, how fast it's moving, and the acceleration of that segment. And based on that, we can calculate what force should have acted, and that is how we get the kinetics, the actual forces, and that's why it's called inverse dynamics. So we have to pay homage to these 4 European gentlemen from the 19th century who did all of the physics and the mathematics by which we are able to do gait analysis today. That's Newton, Euler, Hamilton, etc. So human gait needs 4 things: a control system, which is the brain and the spinal cord, an energy source, which is ATP. We have the levers, which are bones and joints, and a lever is nothing but a simple machine that converts forces into rotation. And we have forces, and forces are called moments in the body because all the forces in the body act about some axis. So there is, because all the joints are movements about axes, so we don't call them forces, we call them moments. There are 2 types of moments. We have internal moments and external moments. Internal moments are those forces that are generated by the body, and external moments are the ground reaction force mainly, or other forces that act on the body. And in kinetics, typically we look at internal moments. So we have to understand this concept of the ground reaction force, which is based on Newton's third law. And it basically says that every action has an equal and opposite reaction. Ground reaction force is the force that the ground applies to your body in order to keep you on the surface of the earth. We take this for granted because the ground reaction force on planet Earth is exactly equal to the force we are applying to the ground. But if we look at certain unusual situations, we'll understand the true nature of ground reaction force. So there is one situation where the body weight is more than the ground reaction force. Yeah. Could anyone tell me what is a situation where body weight is greater than ground reaction force? Anyone on the Zoom platform can unmute yourself and have a go.
During running?
No. So there also, every time you land, the Mother Earth is applying an equal and opposite force to you. So you're moving ahead.
Walking in the swimming pool?
Yeah. Try walking on water. So when you try to walk on water, what will happen is, because surface tension of water is not enough to support your body weight, the body weight is going to go more than ground reaction force and you will sink.
Or Jayanth, right? it would be walking on Moon or Mars. You know, your
that's the other one. Yeah, walking on Moon is when the ground reaction force is more than the body weight, right?
Right.
So because your body weight is 1/6 the body weight on Earth, so your body weight is less, but the ground reaction force, because your muscle power is the same on Moon, so you're applying a much greater force to the ground. So you will actually start to jump much higher on the Moon, applying the same amount of force that you would apply on Earth. So Neil Armstrong is someone who has experienced that particular effect. So there are various components of kinetics, and it's important to understand. So we have forces, which I said are actually called moments in the body, and force times perpendicular distance from the point of application of the force to the center of the joint is basically the definition of moment. So we have internal and external moments, which I spoke about. And we also have flexion and extension moments. So flexion and extension moments are very easy to understand. If the flexors are mainly causing the force generation, it's called a flexion moment. And if it's causing an extension of the joint, then it is called an extension moment. So the other important concept we need to understand is power. And power is work done in unit time. And this is also F times D, but remember that this is a capital D. So capital D is displacement. Yeah. So that is distance. Perpendicular distance is small d. Capital D in physics is perpendicular, is the displacement of the object. And in the human body, displacements are angular displacements. Yeah, it's an angular displacement. So we calculate it in radians or arc degrees. So we calculate it in radians, and then we multiply that by the force, which is in newtons, and it is per unit time. So F times capital D is work done, and F times capital D in unit time is power. So we have two types of power changes. One is power generation and the other is power absorption. So when there is no movement, there is no power. So if you push against a wall, yeah, you are applying a force, yeah, but if the wall is not moving, no work is being done. So if there is no movement of a joint, however much the muscles may be acting and generating force, unless the joint moves, there is no power which is generated. And greater the angular velocity, the faster a joint moves, the more power that is generated. So these are all basic physics concepts that we need to understand.
So Jayanth, I'm just going to interrupt. So if a joint is arthrodisc, the work done is zero. Or if joint is not allowed to move because of an orthosis, you apply an orthosis, the work done at the ankle or power generation is zero.
Is zero, absolutely. So by definition, if you have an AFO on an ankle, there will be absolutely no power generated, even though the plantar flexors and dorsiflexor muscles are working. there is no power that is generated. For power generation, you need movement. That is why stiff joints are not good joints. That is why joint stiffness is never considered good for gait, because you're not generating any power. So I will just show two situations. This is my son who is throwing a ball. So he's throwing the ball. So here, let's look at the movement and the force. So he's throwing the ball in this direction and he is applying the force in the same direction. So when movement and force are in the same direction, it is called power generation. So the second one is where he's catching a ball. So here the movement of the ball is in this direction and the force that he is applying is in the opposite direction. And this is called power absorption. So this is a very simple way of understanding whether power generation is happening or power absorption is happening. So let's go back to the graphs again, which Chasanal has just introduced us to. I will explain these graphs. So this is basically the sagittal plane graphs at the hip, the knee, and the ankle. Yeah, so these are kinematic graphs, and these are normal graphs. You can see that the red and green lines are exactly following the normal gray band. So this is a normal graph. So that line is the division between swing phase and stance phase. You can see that the line is exactly at 60%. So let's just see what is happening and understand kinetics. So if you take that particular part of the ankle kinematic, so that's basically the third rocker when there is rapid plantar flexion of the ankle. Yeah, there is rapid plantar flexion of the ankle here. And at the same time, because there is concentric action of the calf muscles, you are getting a big ankle movement. And this is a plantar flexion movement. So when you have a plantar flexion movement and a plantar flexion movement, both are in the same direction, you get a massive amount of power generation. And this is called the A2 burst. And this particular power is the main motor for human walking. So that is why in comparison to all the other power generations, you can see how much of power is being generated during the third rocker of gait at the ankle. Let's look at another situation. So here, again, we are looking at pre-swing at the knee. Yeah. So the knee is flexing, getting ready for swing. So it is still in the stance phase, but it's getting ready for swing. And the knee is flexing up to 40 degrees, as Chasanal mentioned, before the foot actually leaves the ground. So this is pre-swing. So the knee is flexing. And you can see at the same point that there is an extensor movement. So the reason you have an extensor movement at this point is basically to break that action and to control that action. So whenever you have knee flexion, yeah, the movement is knee flexion, but the force is an extensor movement. So when they are, both of them are in opposite directions, you can see that there is power absorption at the knee. Yeah. So when you have movement and movement in the same direction, there is power generation. And when you have movement and movement in opposite directions, you have power absorption. So these are all basic concepts that I thought I would introduce. So let's look at
Jayanth, just one more clarification. When you have movement and movement in same direction, it is concentric contraction. And when they are in the opposite direction, it is an eccentric contraction. Is that true?
Yes. So typically power absorption happens during eccentric contraction. So they are all controlling movements, whereas power generation movements are basically concentric contractions. That's when the body is propelled forwards. So let's look at an example at mid stance. So this is a period of energy conservation when there is hip extension happening because of the gluteus maximus extending the hip. The knee is also progressively extending, but this is happening passively. Yeah, and the ankle is also passively dorsiflexing under the control of the eccentric contraction of soleus. So this is mid stance of gait. So these are Dhiren's very nice illustrations that shows how the knee is extending, the hip is the knee is extending, the hip is extending, and the ankle is passively dorsiflexing. So there is concentric contraction of the soleus, and the ground reaction force is anterior to the knee, and the ground reaction force basically pushes the knee back. So not much work is happening at this time, is what I'm trying to show. And if you look at the power graphs, you can see that there is hardly any power generation or absorption happening either at the knee, the ankle, or the hip. So there is hardly anything going on because this is a period of energy conservation, which is in mid-stance. Compare that to pre-swing, which is a period of propulsion, when the hip is flexing, the knee is flexing. So at this point, the opposite leg has reached the ground, the ipsilateral limb is getting ready for swing, and the gastrosoleus propels the body at the time of push-off, and this accounts for 50% of propulsive force. And this is the point at which you can see that there is power generation at the hip because there is a flexor moment at the hip. The hip is still flexing, and therefore you get power generation here at the hip. And at the ankle, as we previously saw, the ankle is plantar flexing, there is a plantar flexion moment, and you get this huge A2 power burst. At the knee, nothing much happens because the knee is basically to do with energy conservation. Most of the power generation happens at the ankle. About 50% of power generation happens at the ankle. About 30% of power generation happens at the hip. The knee acts as a trader of power between the hip and the ankle.
Jayanth, just go back to the last slide. No?
Yes.
Sorry to interrupt, but there's an important question. One more back. Yeah. So if you see here, the magnitude of ankle power generation, if you see on the graph, seems to be much more than at the hip. So is this proportionate, or it is just to accommodate the graph that these scales are applied? So because many times people get confused and they feel that a lot of power is being generated at ankle and little is generated at the hip, looking at these graphs. So would you like to clarify that?
No, the scale is the same. If you see the ankle is in watts per kilogram, and you can see that the scaling of all three are the same. So these are proportionate amounts of power that are generated at the three joints.
Right.
Yeah. So this is the scales are proportionate. So, but that is a relevant point. So you need to really watch the scales.
So because the hip controls
of angles,
limb, it is kg, it is watts per kg. Per kg, the power produced is less, but the ankle controls only the foot. And that's why that ankle burst appears to be much more than, so it appears that ankle is doing much more work than the hip. It's not so.
You mean in terms of absolute terms
values?
How much? Obviously, because the iliopsoas is iliopsoas and the gluteus maximus are like 3 times the size of the gastrocnemius. So
they have to carry larger loads.
Absolutely. So that's true. So the absolute amounts of power that is done by these muscles is greater, but the proportionate contribution that they make. So they're all the sizes of these muscles have through evolution and by nature, they have all been determined to be exactly right for the human body. For the human anthropometry, these muscles are all of the right size.
And one more question from the audience. I'm sorry to interrupt you, but you spoke about A2 power burst. If there is an A2 power burst, there has to be also A1 power burst. So what is it? That can you just
A1
clarify?
Is here, and it's a very small ankle power generation, and that happens at this point where you get plantar flexion and then dorsiflexion. So when you get that little change in the movement, this A1 happens. This A1 will become more significant. In a normal person, A1 is hardly noticeable. But when you have a 4-year-old child who is walking with significant spasticity and an ankle equinus, you will get a double bump at the ankle. So, and we will look at cases when we discuss the kinetics of, young children who are walking with a very bouncy gait, children with spastic diplegia. You'll see that they have 2 big bursts, 2 big ankle bursts. The first one is when they land, and then there is a contraction because of spasticity of the calf, and then they'll get 1 power burst, and then they'll go into dorsiflexion again, and then you'll get the second power burst. So that becomes more obvious when we have pathology.
Yeah, please go
I
ahead.
hope that's clear.
Thanks for that.
Great. So, like I said, that is the double bump ankle. So the double bump ankle pattern is when you have spasticity, and excuse me, we'll discuss these cases as we go forward. We have something called a knee extensor movement pattern, where the knee extensors dominate in order to keep your body from going into crouch. So this happens in patients who have crouch gait. And you also have a knee flexor movement pattern, where you have some children who are in recavatum gait, where the knee flexors are working more and generating more flexor power in order to control that excessive hyperextension of the knee. So these are all common ankle kinetic patterns, kinetic movement patterns that, excuse me, that we see in our clinical practice. So kinetics helps to explain the kinematics. So we helps to understand which are the dominant muscle groups that are active and what the ground reaction force is doing at any point of time. And treatment that will best normalize the kinetics will improve the gait efficiency maximally. So it helps us to explain the gait pattern, and it also gives us some kind of target that we should be aiming towards so that gait efficiency is normalized. So, thank you.
Thanks, Jayanth. Typical Jayanth style, and we saw excellent graphics from Dr. Dhiren Ganjwala here. So it's a difficult topic, but I feel, looking at kinetics and kinematics again and again in a normal patient and in pathological situation. So repetition helps us to understand them better. And what's going to help people is to repeatedly watching these videos, these two videos, to understand these things. Any questions from the audience here? So Jay, I just wanted to ask you one question that, many times people just look at kinematics and disregard the kinetics. So in which clinical situations kinetics become, really tell you about decision making in cerebral palsy? How do you use them? Yeah.
So it is good in any gait lab for us to go through everything, all the modalities in every case. So this is some kind of discipline that we need to cultivate within all the gait lab groups, so that when you discuss a case, you do it in a very, very systematic manner: history, physical examination, 2D videos, kinematics, kinetics, and EMG. So, and as many modalities as are available for a particular patient, all of those modalities should be discussed. Whether it is of relevance in a particular case, so there is no a priori assumption that kinetics will really help us in one case or it will not help us in another case. You really don't know when it will help you. So you must do it in every single case and try and make sense of the data. And a lot of times when the data doesn't make sense, that's when real understanding happens. So we start to question why this particular movement is happening or why this muscle is acting. And that gives us ideas as to why the abnormality is happening in the first place. So it is just done as, I don't think there is a ready-made answer to that. The answer to it is just do all the modalities in every case and analyze and understand and explain every single movement in the graph. So every single movement in every single graph has to be logically explained, and it has to be correlated with the history and the physical exam. So you have to do that. And what I have is a tick box in my mind. So I tick, 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 everything ticks. Then I say, okay, then I'm on the right track. If there are the fewer the ticks there are, then I know, okay, there's a problem. And then where's the problem? Is the problem in my data? Is my marker position not correct, or there is some other issue? So usually we find in 9 out of 10 cases, everything just adds up beautifully. So when you have a child walking in crouch gait, you will see a knee flexor pattern. When you have hyperextension gait, you will see a knee extensor pattern. So it all works out beautifully, but you do have those cases where it doesn't match up, and that's when we really need to start looking very closely at whatever assumptions we have made, and that I feel is the value of gait analysis.
So one technical question, sir, for small kids or kids who kind of have jump gait or slow walking kids with crouch, many a times both the footings come on the force plate. So how do we use that data? Because that completely becomes invalid. So any particular technique?
So what you can do is just take one of the feet. So there will be a brief instant of time when only one foot will be on the force platform. Yeah. So you can select only that portion of the gait cycle and label that as right lower limb. And then ignore, for that particular gait cycle, ignore the left side. When the left comes into contact with the same force plate, just ignore that particular part of the data. And then in another gait cycle, you take the left. So don't try to do left and right kinetics in the same gait cycle. So do it from two different gait cycles. And because we do summations of multiple gait trials from 3 or 4 different, or maybe 6, 7 different gait trials, when you get the summative data across gait trials, it becomes the system is able to use the kinetics for the right lower limb from one trial and kinetics for the left lower limb from another trial. So the system is able to match that. So that's the way we have been doing it.
Okay, so I wanted to contribute something here. So I was doing I studied ACL subjects gait, and what I noticed that answering Taral sir's question, that in those cases the kinematics comes to normal after rehab, but there is a very specific kinetic normalcy. The kinetic normalcy does not occur. There is a specific evidence of quadriceps avoidance which we can pick from your kinetics only. So in those cases, looking only at kinematics does not help, and the compensations basically occur in kinetics where quadriceps is not working so much so, and hams with co-contraction is aiding. So I got these in the graphs when I was doing my study on the ACL subjects. Just wanted to put a contribution here.
So whenever you have instability, this is going to happen. Another situation where this is going to happen is pain. When you have an antalgic gait, you get decrease in power generation because the force becomes less. The ground reaction force also becomes less on a painful limb.
Because the muscles are inhibited.
Agree, sir.
So, I mean, there are lots of complex kinetic gait patterns that have been described, which we will discuss in the sessions going forward. But because this is an introductory session, I thought we will just get our terminologies with regard to kinematics and kinetics so that everyone is on the same page.
So Jayanth, I want to just put an open question to everyone who's present on a Zoom. Those who have a gait lab, I just want those who have a gait lab with a force plate, just write yes in your chat box. And those who have gait labs without force plates, write no in the chat box. And let's see what is the answer. Jayanth is quickly to answer yes. And I'm going through the chat box here. Let me see. More answers expected. Yeah, yes. Yeah. So I think most of the people who are answering, thankfully, everyone has gone for a gait lab, with the force plates, and kinetics are as important as kinematics, though they are difficult to understand. But and as we go along, studying more cases and discussing more cases, I think these issues will become more common to all of us.
And also, kinetics is a very good indicator that you have actually corrected the gait pattern, and it also tells you how much extent you have corrected the gait pattern. And in cerebral palsy particularly, the knee should be very quiet. The quieter the knee on the kinetics, on the power graphs, the more efficient the gait pattern. Right. So if you get wide power generations and absorptions at the knee, then
it's an eccentric.
The gait is still inefficient.
Either power generation or absorption, which should not be happening.
Yeah, it should be very
One
quiet.
question, a lot of time therapists ask, and in fact, people have sent me cases for gait analysis, saying that this patient has weakness of this muscle. So can kinetic show you weakness in a particular muscle? For example, in crouch gait, if quadricep mechanism is weak, or there is less work generated by glute soleus or gastrocnemius, will your kinetic gait analysis be able to show that?
Because we don't represent individual muscles,
Right.
in kinetics. So all we are looking at is very crudely, we have said knee extensor and knee flexor. But we know that there are situations during normal gait when the hamstring works to extend the knee, because it's a closed chain kinetic, because when the foot is in contact with the ground, the hamstring is actually working to extend the knee. So the hamstring is actually a knee extensor. So for purposes of ease of understanding and convention, we are dividing the knee moment into an extension moment and a flexion moment. But in real time, in real situations, the situation is not so simple. So it's not, so if you get someone who is in excessive knee flexion, you will naturally get a knee extensor and an excessive knee extensor moment to try and hold them up against gravity. So you'll see a knee extensor moment pattern. And if they lose that battle, they'll sit down, right? They can't stand up anymore. The only way you can stand up in knee flexion is to increase your extensor moment significantly to 2-3 times of normal. So
in short, kinetics is all about the joints and movements around those joints. It has nothing to do with muscle power.
It doesn't have anything
something
to do with muscle
which
power.
is very simple concept we want to share with everybody.
Yeah.
So it's 7:06. I think very interesting session. Thanks, Jayanth and Chasanal. What we are going to do is, if there are no further questions, we are going to stop here this session. Chasanal and Jayanth will have a case discussion session in March. We'll announce the dates, and I hope you have liked this session. Those who are watching this on OrthoTV, if you are associated with the Gait Lab, or you are interested in a deep study of the Gait Lab, or becoming associated with the Masi Association, please you can write to Jayanth or me or Chasanal, or you can just drop a comment on OrthoTV with this session, and we can include you in the Zoom group where actually the live sessions are going on. So with this, with permission from everybody, we would close this session, and we would meet next month again, same day, same time. Thank you very much.
Great. Thank you.
Thank you.
Thanks. Bye.
So